Hello, everyone, and welcome to today's webinar, Neuromodulation in Epilepsy, VNS and RNS, hosted by NeuroPace and the Epilepsy Foundation of Northern California. Before we get started, I would like to go over a few items so you know how to participate in today's event. If you have joined the presentation through the webinar link, you join in listen-only mode using your computer speaker system by default. If you would prefer to listen over the telephone, just select telephone in the audio pane and the dial-in information will be displayed. You will have the opportunity to submit text questions to today's presenter by typing your questions into the Q&A or the chat panel at the bottom of your screen. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. Today's webinar is being recorded and you will receive a follow-up email with a link to view the recording. I would also like to welcome those watching via Facebook Live. You can ask questions throughout the live stream by leaving a comment on the video. I would now like to introduce our speaker, Dr. Rao. Dr. Rao is a neurologist and epilepsy specialist at UCSF Medical Center. He is also an assistant professor of clinical neurology at the UCSF School of Medicine. Dr. Rao?
Thanks, Allie, and hi, everyone. Thanks so much for carving out a little bit of your Friday evening to join us. I'll try to make it worth your while because we're going to talk about really what I think is one of the most exciting areas in clinical epilepsy today, which is neuromodulation. And we're going to be talking specifically about two available technologies, one called VNS and one called RNS. These are my disclosures, and here is a roadmap for how we'll go through these topics. So we'll start with a brief introduction into the concept of drug-resistant epilepsy. I'll review some of the currently available treatments, and then we'll start talking about what neuromodulation is and the two technologies that we have available now, VNS and RNS, and then we'll wrap up with some take-home points. So just by way of introduction, we'll start with a few definitions so that everybody's on the same page. A seizure is an episodic neurological event, and we can think of it as an electrical storm in the brain. One of my patients actually calls them power surges in the brain, which I think is a good analogy as well. And seizures can come in very different manifestations. They can produce altered movement, sensation, experience, or consciousness. I like to say that almost anything the brain can do, a seizure can look like. When we use the term epilepsy, we're referring to a clinical condition in which there is a chronic tendency for recurrent unprovoked seizures. And epilepsy among neurological disorders is very common. Only migraine, stroke, and Alzheimer's disease are more common than epilepsy. And in fact, epilepsy is more common than multiple sclerosis, cerebral palsy, and Parkinson's disease put together. Epilepsy affects anywhere between 0.5 and 1% of the population. So in the US, that's somewhere between 2 and 3 million people. The lifetime prevalence of epilepsy is 1 in 26. And the causes of epilepsy are quite diverse. I actually say that anything that is bad for the brain could potentially lead to seizures, including strokes and tumors, trauma, infection, genetics, etc. How do we diagnose epilepsy? Really, epilepsy is a clinical diagnosis, and what that means is that you don't actually need any particular test to tell you that a patient has epilepsy. What we rely on the most is actually the clinical history, and that's why you'll find most epilepsy neurologists are kind of stickler for details because details matter, and the description that a patient provides of their seizure symptoms provides some of the biggest clues for what might be going on. When we do other tests, the two that we typically start with are a brain MRI scan, which tells us nothing about the electrical activity of the brain, but it does give us our best picture of brain structure. And then we do an EEG, which again tells us nothing about brain structure, but does measure brain electrical activity. And so those two together, the MRI and the EEG, in the context of the patient's history, is really how we start to figure out what might be going on. When I first sit down with a patient and hear their story of their seizures, what's going through my mind is trying to categorize the symptoms that they describe into a particular type of epilepsy. And there are many ways to classify seizures and epilepsy, but broadly speaking, there are two categories. The first is what used to be termed partial onset seizures, and that refers to seizures in which the abnormal electrical activity starts in one particular spot within the brain. And it can cause symptoms by virtue of what that part of the brain normally does, And that activity can spread from the spot to the rest of the brain. That's what we call secondary generalization. Often when seizures spread from a single spot is when patients will have whole body convulsions, or so-called grand mal seizures. There are some newer terms for partial onset seizures because people realize this isn't partial anything, it's a full seizure. It just is one that comes from a focus. And so the term that I like is focal seizures. You might also hear localization related seizures, but really all of this means the same thing. The second broad category of epilepsy is called generalized onset, or some people say primary generalized seizures. And that is a situation in which the abnormal electrical activity doesn't start in just one spot that you could put your finger on. It starts actually all over the whole brain all at once. And it's important to make a distinction between these two categories of epilepsy because the treatments that we can offer differ based on which category you are in. Those treatments are pretty much summarized completely in this slide. This is the whole universe of epilepsy treatments. And the first thing that we do is sort of the simple thing. Well, it's simple to suggest, but sometimes hard to do, and that's behavioral modification. So sometimes patients will come to us and tell us that they really only have seizures in the setting of, for example, sleep deprivation or alcohol consumption, or maybe they're well controlled with medications, but on the rare instance when they forget to take their medicine, they might have seizures. In those circumstances, the best way to treat somebody might be to address those modifiable factors. So to avoid triggers, to develop strategies for taking medicines more faithfully. But most patients find that behavioral modifications alone are not sufficient to control their seizures fully. And so really the mainstay of our initial treatment is with medications. And wow, we have a lot of medications. This slide sort of makes that point. We have over 30 different medicines available at our disposal. And you can see that they've been developed at an exponential rate going back to the early 1900s and even before then. That's the good news. The bad news is that in spite of all of these choices that we have, we are not that good as a field at moving the needle on the rate of patients for whom medicines is not the full answer. So comparing 1881 to 2012, despite the development of so many new medicines, we are still in a situation where 1/3 of our patients are drug resistant, meaning that the medications alone do not fully control seizures. And that's disappointing in terms of progress in our field, but it's an important observation to make. This is another way to look at that. So if we think about 100 patients with newly diagnosed epilepsy who come to your clinic and you choose a medicine and give it to all of them, you will get on average about 47% of those 100 patients seizure-free with that first drug. So that's pretty good, about 50-50 for the first shot. So then you try a second medicine for the remaining patients and you will get another 13% seizure-free with the second medicine. You try a third medicine or maybe combinations of medicine and you get another 4 of those patients seizure-free. And you can see that there really is this diminishing returns. And that's why we say after you have failed even just 2 medicines, the odds just statistically that any medicine is going to be the solution for you really starts to drop. And that's how we define this category, this 1/3 of our patients who are drug resistant. If you've tried an adequate trial of 2 or more medicines and still have seizures, you might be in this drug resistant category. And unfortunately, you would have a lot of company in that category. By some estimates, 800,000 patients in the United States live with seizures that persist despite them taking anti-seizure medications. After you've tried 2 medicines even, the odds that a 3rd or 4th or 5th medicine is going to completely control your seizures really dwindles, as I said on the previous slide, to less than 5%. So those are pretty sobering odds. But the take-home message from that is actually not one of disappointment. It's one, I would think, of hope, because what we want for these patients who are in this category is for them to be evaluated at a so-called comprehensive epilepsy center, or a CEC. There's many of them, over 140 of them all around the country. And these are centers that are dedicated to patients with drug-resistant epilepsy, and they can provide specialized care with a team of providers, including epilepsy neurologists, neurosurgeons, neuropsychologists, epilepsy nurses, and other team members. Unfortunately, as things stand now, only 1 in 5 patients with drug-resistant epilepsy ever actually get seen at a comprehensive center. And I think that I would like going forward for us to do better than that, because I think there's a lot more people who could benefit. What are the current treatments that you might get at a comprehensive epilepsy center? Well, those are summarized in this slide here. These are the things that can be offered at a facility that really is dedicated to taking care of patients with drug-resistant seizures. We're going to talk about all of this, but we're going to first talk about what's called resective surgery. Resection means removal of brain tissue. And so when you go to a comprehensive epilepsy center, one of the first questions is going to be, well, if these are focal seizures, where is that focus? Where do the seizures actually come from? And that can be a surprisingly challenging thing to figure out. The evaluation begins with non-invasive tests like EEG and MRI that I mentioned, and also a variety of non-invasive imaging modalities that can provide clues that we can fit together and try and make a case for why seizures come from one spot versus another. Some patients where that workup is not sufficient to fully localize seizures go on to have more invasive testing where we actually implant electrodes directly into the brain and measure where the seizures come from in that way. One way I like to think about this is to say, if we're thinking about epilepsy surgery and removing brain tissue to treat seizures, we have to know very precisely where the seizures come from. So sometimes the non-invasive tests might tell us the state and the city and maybe the neighborhood where the seizures come from, but what we really need is a precise street address, and sometimes we need the invasive monitoring to give us that information. So let's talk about epilepsy surgery. Let's say we figured out where the seizures come from. What does that mean to have epilepsy surgery? Well, it essentially does involve permanent removal of seizure-producing brain tissue in hopes of actually curing seizures for that patient. And in the best case scenarios, the rates of seizure freedom with surgery can be 80 to 90%, which is terrific. Laser ablation is kind of the new kid on the block when it comes to epilepsy surgery. This is a less invasive way using a catheter that gets heated at the tip to destroy the tissue that's causing seizures while leaving much of the rest of the brain unaffected. But this slide tries to make the point that although epilepsy surgery is so good when it's good, it has its own limitations, and that's true for laser ablation too. This patient that we're showing here is probably the most famous patient in the history of neuroscience. His name is Henry Molaison. He went in the literature by the initials HM. HM had a history of traumatic brain injury as a child, and he developed epilepsy in his teens. By the time he was in his 20s, he was very disabled from his epilepsy in spite of being on multiple medications. And he agreed to what was then an experimental neurosurgical procedure in which his temporal lobe on both sides was removed. And that actually helped his seizures, but it left him with a very devastating amnesia syndrome where he never made another new memory again. He was studied for decades so that we could learn everything about his condition. He taught us a lot. What he really taught us is that epilepsy surgery has limits, and there are certain areas of the brain that we simply cannot remove. Let's talk about the treatment gap then. So we talked about how common drug-resistant epilepsy is. I mentioned that epilepsy affects about 1% of the population, maybe about 2 or 3 million people in the US, and 1/3 of them are drug-resistant. That means there's 1 million people or so with drug-resistant epilepsy. And by contrast, only 20,000 of them make their way to a comprehensive epilepsy center and get video EEG, which is the first step in a pre-surgical evaluation. So that's a referral gap. We need to do better getting patients to these centers. But then even of those 20,000 patients, only 3,000 epilepsy surgeries are actually done. So there's also a treatment gap. And the reason for that, there might be several, but in many cases, patients are not candidates for surgery because it would be too dangerous. It would be associated with a risk of unacceptable deficits, like in the case of HM. Or some patients just don't want surgery because it's irreversible when you do it. And it's really this group of patients for whom we start to think about other things besides surgery, and neuromodulation is really first among them. So let's talk about what does that mean, neuromodulation. Going back to our table, it's these procedures shown in the box that we'll be talking about next. So neuromodulation is a concept that means electrical stimulation of brain tissue without actually removing it. And how might that be beneficial? Well, maybe electrically stimulating the brain in some way might make it harder for the brain to make seizures. It might raise the threshold for starting a seizure. Or maybe the seizure could start, but somehow electrical stimulation could restrain it and limit the propagation or the spread of the seizures. A lot of the morbidity of seizures comes when seizures spread to involve the whole brain and people lose awareness and can fall and hurt themselves. Or maybe electrical stimulation could actually stop a seizure in its tracks, abort a seizure, if you will. Or maybe it's something a little bit more complex, like making the brain circuits less excitable, less prone to making seizures in some way. All of these things are possible and they're not mutually exclusive. There are two FDA-approved therapies for neuromodulation in epilepsy currently, and we'll talk about the first one, which is vagus nerve stimulation, or VNS. This slide summarizes VNS therapy. So a VNS is a small battery that's implanted under the skin, usually in the left chest, and the battery is connected to a wire that gets tunneled under the skin into the left side of the neck, where it is wrapped around a nerve called the vagus nerve. The vagus nerve is an important nerve that mediates a lot of normal functions in our body, including regulating heart rate and gut motility and blood pressure and so forth. But it turns out that stimulating the left vagus nerve with electrical pulses allows some of those pulses to hitch a ride, if you will, on the nerve and go up to the brain and reduce seizures. The device itself is implanted in a short outpatient procedure. It typically takes an hour or two. Patients usually go home the same day. And the VNS can be turned on as early as a week or two after surgery. So what's good about this? Well, one thing is that it's been around for a long time. So the first VNS implant was in 1997, which means we have 20 years of experience with this device and over 85,000 patients currently implanted. Another advantage of VNS is that because you're really working only on that nerve in the neck and not directly in the brain, you don't have to know so precisely where the seizures come from. Because in some patients it can be very challenging to figure that out. VNS works for both of the main categories of epilepsy that I described, both focal seizures and generalized seizures. And it comes with a magnet that patients can swipe over the battery that allows the device to deliver extra stimulation when patients feel they need it. So for example, at the very beginning of a seizure, if you swipe the magnet, you can have the device deliver additional stimulation. And one final benefit is that this device is MRI compatible with certain protocols. Nothing's perfect, and the VNS has its own challenges, one of which is that the left vagus nerve actually sends a branch to the vocal cords. And so some patients, when you stimulate the vagus nerve, will actually feel some throat irritation or have a change in their voice or cough, or it will disrupt their sleep. This is not always a prohibitive thing, but many patients do describe this. VNS, by working in the neck, doesn't really work at the source of the seizures. The seizures come from the brain, no matter how you slice it, and yet the stimulation is happening in the neck, somewhat removed from the site where the seizures begin. And furthermore, the stimulation with VNS is essentially on all the time, and it's not responding dynamically to what's happening in the brain. That said, some of the more recent models have tried to close the loop, as it were, and to detect physiological changes that are happening in the body during a seizure and to respond to them. One of the VNS models, called the Aspire, is capable of responding to changes in heart rate during seizures. This is a bit of a complicated slide, but what I'm trying to show with the black squiggly lines is that this is a seizure that's starting, and many patients will have an abrupt increase in heart rate at the beginning of their seizures. This particular model of VNS can sense that change in heart rate and can assume that a seizure is happening and can use that to deliver additional stimulation at that moment. And sometimes, as in the case here, that stimulation actually led to termination of the seizure. The most recent model of the VNS actually has some really nice improvements as well. This is called VNS Sentiva. And some of the features of this model are that you can do, first of all, scheduled programming, which means that instead of patients having to come back to clinic every few weeks for us to dial up the settings progressively, the clinician can actually program in a schedule of settings changes where the device will automatically ratchet up the stimulation at pre-programmed times. Similarly, some patients have seizures at preferential times of day, for example, only nocturnal seizures. And for those patients, it's possible to differentially program the settings for day or night, for example, providing more stimulation at nighttime when a patient might need it the most. And finally, this version of VNS is sensitive to changes in body position. So it can actually know if a patient is, for example, lying face down, as might happen after a big generalized seizure, and it can actually make recordings of that that clinicians can review, and that can be very helpful to fold into clinical management. How well does this work? There's been a lot of studies on VNS. I'm showing the results from one here. The bars here show you the percentage of patients, or rather the percentage of patients who had a seizure frequency reduction of a certain amount. So the first bar says that 64% of patients had at least a 50% reduction in seizure frequency. The second bar shows that 41% of patients had a 75% or greater reduction in seizures, and about a quarter of patients had a really good response, over 90%. This was a tough patient population. They had been on a lot of medications. they'd had epilepsy for a long period of time, and up to 30% of them had prior surgery in the past. Another interesting observation is that the efficacy of VNS, and as you'll see later, also RNS, looks like it improves with time. And so there is efficacy on the short term, but it seems that the longer that patients are treated with this therapy, the better that they can do. There's also evidence that in thinking about the two main types of seizures, focal seizures and generalized, there's evidence that VNS might be particularly effective for patients with generalized seizures. This was a meta-analysis, which means that it pooled a lot of prior studies and tried to make some cohesive conclusions by combining the data. And what they found is that the patients who actually did the best were the patients with generalized seizures compared to those with partial or focal seizures. Okay, let's pivot now and talk about really a very different neuromodulation treatment, which is called responsive neurostimulation, or RNS. And the concept of RNS is really very different than VNS, and I've tried to illustrate that on this slide. So the squiggly line that you see there is a section of EEG. So this is the brain activity of a patient. And in red, the brain activity looks normal for the first little while. And as you get along to where it turns blue, that is abnormal activity, the kind of activity that tells us that a seizure is just about to happen. And the device is continuously sensing brain waves. It's looking for these patterns of abnormal activity, and it responds to detection of that activity by delivering electrical stimulation. And in this case, you can see that delivery of electrical stimulation actually helped normalize the brain waves. And if the brain waves are normal, the device won't stimulate again. So the key concepts are that it's continuously listening to the brain activity, it's identifying key patterns of activity that look like it's a seizure starting, and it's trying to stop that activity by responding with electrical stimulation. The RNS device is shown here. The neurostimulator is not placed in the chest like it is with VNS. It's actually placed directly in the skull. It does not touch the brain, and actually it sits completely flush with the skull, so there's no bump that protrudes. There's really no cosmetic difference. You can't tell if somebody has this implanted. The neurostimulator itself is connected to two lead wires, and those are implanted in the brain right at the site where seizures come from. So again, a difference with VNS. This is working right at the site in the brain where the seizures come from. After implantations, patients typically spend a night or two in the hospital. And in thinking about how long the battery lasts, with average settings, it lasts for about 4 years. And the replacement procedure is a much simpler procedure, about 45 minutes outpatient procedure. Patients go home the same day. We call it actually not just RNS, but the RNS system. And the reason for that is that it's a system of interconnected components. One of them we've just looked at, which is the neurostimulator and the lead wires themselves. But when patients go home with the RNS system, they actually get a laptop that they take home and a wand that they can hold over the device and download data on brain activity that's stored by the device. Then they can send that data over the internet to their providers who can review them remotely. So this is really a very different thing than anything else we have available in neurology, where patients are able to directly transmit recordings of brain activity to their treating providers who can sort of interpret that and make treatment decisions based on that. So I'm showing that here, that RNS enables these chronic recordings of brain activity. Patients download and transmit data from home. Providers log into a secure online website and view those recordings. This, it turns out, has huge advantages. And the way that I like to think about it in terms of an analogy is to think of a camera. And to say, well, this is not necessarily a better camera, but it's one with a longer exposure. So if you think of a routine EEG, which might last 20 or 30 minutes and is done in a clinic setting, and you took a picture of the night sky with a short exposure, you might see something like this. I like to think of chronic EEG as being the same camera, but with a longer exposure that lets more light in. It lets you sort of glean more information about what's actually going on, and you get a much richer picture of the dynamics of a patient's epilepsy. For me, in my practice, the luxury of chronic EEG really helps me to optimize management for patients. So historically, what we have done is we've gathered from patients' history, their verbal report of how they're doing, are medications working, how often are seizures happening, etc. And sometimes that history is limited because patients might not remember all their seizures, or they may have seizures in their sleep, for example, that they're not aware of. And we do the best that we can by offering empiric treatments. But in our patients with RNS, we have a much richer picture of what is actually going on. We have the patient's report, of course, which is still the most important. But then we have added information about seizures that they may not be aware of, what kind of seizures they're having and where they may be coming from in the brain, what the effects of medications that we're changing might be, what trends in seizure activity over time might be, and all of that information we can synthesize to optimize management for our patients. So this is really a great thing for clinicians and patients alike. Let's talk about efficacy with RNS. So again, like VNS, the improvement in seizures really seems to progress over time. So this graph is showing you from year 1 out to year 7. We actually now have 8-year data, long-term data that shows that patients can get over a 72% reduction in seizure frequency over time. Very impressive. And quality of life can improve with the RNS system as well. In addition to the overall seizure frequency reduction, 30% of patients will have 6-month periods of seizure freedom. And that kind of response in a very treatment resistant population is incredibly meaningful in terms of physical health, cognitive function, mental health, and less worry for patients about seizures. That's why the RNS system is becoming an increasingly popular treatment option that's available at comprehensive epilepsy centers. Over 1,500 patients have been treated to date. RNS system is available in almost all comprehensive epilepsy centers in the country. Insurance companies are covering this because they're realizing that this is an effective and safe therapy that really benefits patients. And it's gotten some favorable press in the news and other media outlets as well. So if you are interested in learning more about the NeuroPace RNS system, there's a number of resources that are available to you. I would suggest starting with the website, which is shown here, www.neuropace.com. It's really very patient-friendly. There's sections for clinicians and sections for patients. There's patient testimonials. There's information about how the technology works. It's really a rich source of information. We can get our patients so-called patient resource kit that has a lot of useful informational material. There is an RNS community chat, which is a free monthly call where you can sort of hear the perspective of providers who work with RNS patients and patients themselves. And if you really want to get this, I think is the most valuable thing, which is, you know, it's one thing what your doctor says, but it's probably far more meaningful what real patients say who've actually gone through this and knowing what their experience is. And NeuroPace has a program called the RNS Ambassador Program, where patients who actually have the RNS system can share their experiences, what their fears were, how they did, what was easier than what they thought, what was harder than what they thought. They can share that with prospective patients. And so I think that can be a very meaningful connection that we can help set up as well. So are you a candidate for the RNS system? Well, it's only approved for patients 18 and over who have frequent disabling seizures that impact your quality of life. And you have to be drug resistant, meaning that two adequate trials of medicines have not fully controlled seizures. And this only works for focal seizures, not for generalized seizures. So the benefits here are the efficacy data, as we saw, are excellent. RNS works directly at the seizure onset zone, the part of the brain where seizures come from. People often ask, do you feel the stimulation when it's actually delivering electricity to the brain? And the answer is, in general, no. The stimulation is imperceptible and the device is working essentially by itself all the time. It's listening for those abnormal patterns of activity and it's stopping seizures completely unbeknownst to patients. So there's not a lot that patients actually have to do for the device to work, and the stimulation, as contrasted to VNS, is not perceptible. And of course, we get the chronic EEG data that I mentioned as well, which is very important for providers. As I said before, nothing's perfect. And so with RNS, the considerations that are still challenges are that currently MRI is not allowed once you have the RNS system implanted. We expect that probably within a year's time or so that will actually change and we'll be able to do MRIs, but for the moment, that is not allowed to get an MRI. As I mentioned, it is not approved for generalized epilepsy. The implantation procedure probably is more invasive than VNS because it does involve brain surgery. It's a very safe implantation procedure, but it's different than having surgery only in the chest and in the neck. And currently, RNS is not approved for children. So if we take a kind of head-to-head and summarize some of the points that we hit on, what are the differences between VNS and RNS? Well, they work very differently in terms of where stimulation is delivered. VNS targets a nerve in the neck. RNS targets the seizure focus in the brain. They differ in terms of when stimulation is delivered. VNS in general is set to pre-specified intervals of time, so on for a certain amount of time, off for a certain amount of time. Whereas RNS really only responds to seizures. So if there aren't any seizures, it's not delivering stimulation. It really is sort of an on-demand stimulation modality. The amount of stimulation is very different. So VNS is stimulating in a scheduled intermittent way all day, and that can be up to 250 or more minutes of stimulation per day. RNS is only stimulating when you need it, and so the stimulation total duration per day is less, often less than 6 minutes per day. The stimulation side effects can be different. So with VNS, some patients do perceive the stimulation in terms of changes in their voice or a cough or changes in sleep. With RNS in general, stimulation is not perceptible. And then finally, VNS, the implantation procedure, does not require brain surgery, and you don't have to know where the seizures come from. Whereas RNS, although you do have to do those things, you do have the benefit of having chronic EEG data, chronic recordings of brain activity that can be helpful for clinicians. So this is one of the last slides, which is what is the kind of decisions that goes into our thought process when we're thinking about RNS or VNS. And I would say the factors favoring RNS are it's only for adults, and you do have to know where the seizures come from. And if a patient has one or two seizure foci, meaning that different places in the brain where seizures come from, and if surgery is either not safe or not possible or just not desired by the patient, and if you think that data about brain activity would be valuable, if any of these things are true, I would say that would sway me towards RNS. On the other hand, if you had a pediatric patient, or if you didn't know where the seizures come from, or if you knew where they come from, but they come from many different places in the brain, or if your patient has generalized epilepsy, or you think that they may need an MRI in the short term, then those factors probably favor VNS. Nobody would expect patients to be able to completely parse this decision because it's very patient-specific and it can be complex, but this is all the more reason why the team of providers at a comprehensive epilepsy center really will help work with you through the pros and cons of different types of modalities. Final point to mention is that this is not necessarily a this or that scenario. In fact, we have a lot of patients who have both RNS and VNS. Maybe they had one technology first and they didn't get the benefit that they wanted. They can definitely go on to have the other type. We also have patients who have had surgery and have gone on to have VNS, or surgery and then later RNS. So I like to think of these more as a and than as an or. And I think it just makes sense to bring to bear the best that all these different therapies have in a given patient to maximize clinical benefit. So in conclusion, a couple of take-home points. So epilepsy is very common, and 1 in 3 of our patients are drug resistant. These patients really should be evaluated in a comprehensive epilepsy center, and as I said, there's over 140 all around the country. I would encourage you to seek referrals to these centers if you haven't already. If for no other reason than for you to be able to hear about all the available treatment options and decide for yourself what might be best for you. Epilepsy surgery can be very effective, but has limits. It's, first of all, irreversible, and in some cases can cause neurological deficits. And for those patients, neuromodulation can be a really good alternative. We talked about VNS and RNS as very different neuromodulation therapies, each with their own advantages and disadvantages. And the final slide that I'll leave you with is really something I believe, which is that all of this really in our field is just the tip of the iceberg. RNS and VNS have taught us that there's a lot that we can offer our patients, even those who have failed traditional therapies like medicine and surgery. And I really think that as the years go by, we're only going to have more and more such options. And so all the more reason to get plugged into a center where you can stay on the cutting edge of those developments. I think I'll stop there, and I'm happy to take any questions.
Thank you so much, Dr. Rao. We're now going to begin answering the questions submitted during today's presentation. As a reminder, you can still submit questions through the Q&A panel at the bottom of your screen, or if you're watching on Facebook, through the comment section. Dr. Rao, our first question is from Denise. Can a person have laser ablation if seizures originate from both temporal lobes?
That's a great question, Denise, and that comes up a lot for our patients. As a rule of thumb, we don't do any kind of procedure that removes the hippocampus, which is a critical memory structure inside the temporal lobe, on both sides of the brain. Whether that's an open surgical procedure or a laser ablation, what HM, the patient that I mentioned, taught us is that if you destroy the hippocampal tissue on both sides of the brain, you're not able to form new memories. And so whether it's from laser or a different type of surgery, in general, we don't do surgeries on both temporal lobes.
Thank you. Our next question is from Samantha. If someone gets the RNS when they get older, do they keep the VNS in as well?
Yeah, that's another great question. That's come up for us on a number of occasions because sometimes patients become interested in RNS after they may have tried. VNS has been around for so much longer that we have patients who've had VNS years ago, and then when RNS became available, they wanted to see if that would help them more. And I would say I've seen it both ways. So some of our patients felt that they got benefit from VNS and they're getting RNS in addition that might help them more. I've seen patients where maybe they just for whatever reason didn't get the benefit that they wanted from VNS, and we do RNS and they do start to see improvements. And some of those patients have requested that we either turn VNS off so they don't have to have the side effects of stimulation, or that if the VNS, they don't perceive a benefit, then they've actually requested that we remove the VNS, which can be done as well. So I think it depends, but we've seen it in both ways.
Thank you. The next question is from Frankie. Should I be concerned about the tingling from my head down to my arms since I got the VNS?
Well, I'm sorry to hear that that symptom has developed. I would say in general, that is not a common symptom. As I said, VNS can be associated with some side effects, but they tend to be more at the level of the neck and the throat. So changes in voice or a cough or throat irritation. Tingling that goes down the arm probably would involve different parts of the nervous system, different nerves and so forth that are not commonly affected by VNS, but without knowing the full specifics of the case, I'm not sure that I could comment more, but that's something that you should probably bring up with your treating providers.
Thank you. The next question is from Kristen. Is the laser ablation you're referring to accomplished with the Visualase system? How widespread is the use of this, and what is your experience with this treatment?
Yeah, great question. Yes, I was referring to Visualase. There are other companies out that make similar technologies, but Visualase is the one that we have the most experience with, and that's the one that involves a catheter that's placed under stereotactic guidance to the structure of interest in the brain. And then the tip of the catheter is heated to slowly destroy the tissue in a very controlled manner near the tip of the catheter. Our experience with this has actually been a little bit mixed, but I want to give a caveat with that you know, we only have about 20 cases that we have done so far. And some of our patients have done great, and they have definitely saved themselves a lot of morbidity from a bigger surgical procedure because it's much easier to undergo a laser ablation. On the other hand, there have been other cases we've seen where it hasn't really given us the full benefit that we wanted, and some of those patients have gone on to have a larger traditional surgery. There are trials that are going on now that are really trying to address in a systematic way what the relative benefits of laser ablation versus more typical types of surgery, like, for example, temporal lobectomies, might be. Because until we do the studies in a controlled scientific way, we're not going to be able to give the information to our patients about how it may fare in comparison to other therapies.
Thank you. The next question is from Denise. Would you need to have invasive inpatient monitoring for the RNS implant?
Great question. The answer is no, that not all patients have to have invasive monitoring. There are scenarios in which the non-invasive pre-surgical workup, which includes EEG and MRI and sometimes other scans, provides enough localizing information that the team feels confident that they know already where the seizures come from without actually implanting electrodes to record seizures directly from the brain. Those patients can go on to directly getting the RNS system. If you know where the seizures come from, you can implant RNS leads in those locations. On the other hand, there are patients where the non-invasive tests might help us hone in, but we don't get a precise enough view of where the seizures come from. And in those cases, you know, we can't just guess and put the electrodes where we think the seizures come from. We really have to know. And those are the cases when we do invasive monitoring. In the RNS clinical trials, about a third of patients had previously undergone invasive monitoring. So that's not 100%. So there were plenty of scenarios in which patients were able to avoid that.
Thank you. The next question is from Kristen. How close is DBS to being used for epilepsy?
DBS, just for those who don't know, is an acronym for deep brain stimulation. And it's almost like a combination of RNS and VNS in a way. It involves electrodes that are implanted in the brain like RNS, and they target a structure called the thalamus on both sides of the brain. But the stimulation is in a sort of scheduled intermittent way in the same way that VNS stimulation typically is, so it's not responding to seizures per se. So in that sense, it's like VNS. Thalamic DBS is actually available and approved in Europe and is being used to treat patients there. The clinical trials for thalamic DBS have been completed and published, and the efficacy data and the safety data looks very good. We are waiting for the FDA to approve DBS for use in the United States. And I don't know exactly when that will happen. We've been told any day now for a little while. I would think within the next year or two, but I don't know for sure. Hopefully soon, because I really think the more options that we have at our disposal, that can only benefit our patients.
Thank you. The next question is from Destiny. With the new VNS, can too many jumps in heart rate later turn into cardiac problems?
Good question. I don't think that there's data to suggest that the VNS causes cardiac problems. What can happen if the device is sensing changes in heart rate very frequently and delivering additional stimulation in response to those detections is that the battery can become depleted a little bit faster than normal. So part of the process of optimizing VNS therapy with the newer devices is actually tuning the device to be just sensitive enough for changes in heart rate, but not too sensitive that it's going off all the time and draining the battery. But to my knowledge, there is not a concern for long-term cardiac symptoms.
And we have one more question from Destiny. UCSF Child Neurology Brain Center is considered a CEC, correct?
Yes, absolutely. Our pediatric brain center is a level 4 epilepsy center. It's part of our program. We actually, the adult and pediatric sides of our epilepsy center work very closely together so that we can share insights and ideas about challenging cases. So we do a lot of epilepsy evaluations in children who are drug resistant. We do a lot of epilepsy surgery in children. In terms of devices, only VNS is currently FDA approved for use in children. That's for ages 4 and up. I expect that in the not too distant future, the labeling for RNS might be, the age cutoff might be lowered, perhaps as low as age 12. That is not the case now, but those discussions with FDA are ongoing. So I think that, that all of the things we've talked about today are absolutely possible at the Pediatric Brain Center here at UCSF.
Thank you. The next question is from Melissa. Since my seizures are coming from the speech area, would my speech be affected with the RNS?
Melissa, that's a great question, and I have to say that I would have thought the same thing. I think that's a very reasonable concern. If you think about it, if your seizures are coming from a movement area or a language area, and then you say we're going to put electrodes on top of that area and we're going to stimulate it, my first thought would be that aren't you going to disrupt the normal function of that brain, like by causing your hand to move or causing a problem with your speech? That's very reasonable. But I will tell you that the experience now with, like I said, 1,500 patients is that that is not what happens. That the stimulation truly is imperceptible even when we are in areas of the brain that have what's called an eloquent function. Eloquent just means that it has a very critical function like vision or movement or speech. Patients do not have disruption in general of those critical functions when we do RNS in those regions. That's a fortunate thing, because often those are exactly the patients who are great candidates for RNS, the patients where the seizures come from an area that we cannot remove surgically. I think the reason why that doesn't happen is that although we're delivering electrical pulses to those areas of the brain, the intensity of those pulses is actually quite low for most patients. So it doesn't, I think, perturb the function of the brain in that area. Also, there's another wrinkle, which is that the frequency of stimulation that we use is a frequency that tends more to disrupt seizures without disrupting normal physiological brain function. So in my practice, having done this for a number of years now with many RNS patients, I have never seen that has happened where something like speech, for example, has been affected. And actually, just this is anecdotal. I don't have a lot of data for this, but I can tell you anecdotally, we have patients who actually say things like when their seizures come from the vision area, they have told me that actually their vision becomes more clear over time. And again, that's an anecdote. That's nothing that has been demonstrated in clinical trials, but patients occasionally say that they, if anything, notice an improvement in the function of that brain region. So to answer your question, no, I don't think it's a reason to not do RNS in those areas.
Thank you. The next question is from Kelly. Is it possible to not detect where the seizures are coming from?
I assume that question means after RNS is implanted, is it possible that you wouldn't record seizures? I suppose that is possible. It is possible that you put the electrodes in an area where you thought the seizures were coming from, but they were actually coming from right next door, and so you don't get a good recording of them. That's uncommon because we're usually quite conservative and careful before we place leads. We like to feel like we're really on top of the seizure onset area. On the other hand, if you are on top of the seizure onset area and you're not getting recordings of seizures, there's a number of strategies that we can do that sort of increase the odds of us capturing seizures in the act. And some of that is probably beyond the scope of our discussion today, but I'll just mention one thing that we didn't talk about, which is that patients who get RNS also are given a magnet, just like the VNS patients, but the magnet has a very different function for RNS. When patients swipe the RNS magnet over their neurostimulator, it actually tells the neurostimulator to store a recording, a snapshot of the brain waves at that moment. And so, for example, if a patient feels a seizure like an aura, or they say, yep, it's about to happen, they can swipe the magnet and the device will grab the EEG, a snippet of the EEG at that time, and then patients can send that to their providers who can look. And often that's what we have to do to see recordings of, for example, very brief seizures or subtle seizures. So there's a number of tricks or strategies that we can do that increase the odds.
Thank you. Another question from Kelly. What is the protocol for finding out where your seizures come from? And I think this is talking about before the implantation of the RNS system.
Yeah, the first couple of steps are pretty much the same for everybody. So it almost always begins with a brain MRI scan that takes a picture of the brain, and we're really looking for areas that look abnormal, that look like they might be the source of seizures, like scar tissue, certainly any developmental malformations of the brain, areas of prior injury, etc. And then the second step is an EEG, where the wires are placed on the surface of the head, and the electrical activity of the brain is measured. And we actually even like to bring people into the hospital and keep them for a few days and capture their seizures on EEG to help us figure out where in the brain the seizures might come from. Sometimes those two tests are all that we need, but there's much more also that can factor into this depending on the results of MRI and EEG. There's a variety of scans and other non-invasive tests that we can do. And what we're really looking for with all of those tests is something called concordance. And concordance just means that if you do 5 different tests that are all different and they all work in a different way and they're all looking for a different thing, but they all line up and they all point to the same region of the brain as being involved in seizures, that really gives you some confidence that that is in fact where the seizures come from. And so we do all of these tests looking for that kind of convergence of data that increases our chance that we really know where the seizures come from. So that's how it starts. And again, the details of that are a little bit different for everybody, but that's exactly what a comprehensive epilepsy center will help guide you through from the very beginning, MRI and EEG, to some of the more sophisticated tests down the road. That's really where that team is going to work with you and share with you along the way what each test, how each test helps us move closer to knowing where the seizures are coming from.
Thank you. The next question is from Samantha. What are generalized seizures and what are localized seizures? From what I understand about my sons is that they cannot trace them.
Right, so a very good question. So those are there are really 2 broad categories of epilepsy. Generalized means that the abnormal activity that happens during a seizure doesn't start from just one spot in the brain. It really starts all over the brain all at once. And we think that in some patients, the network or the wiring of the whole brain is prone to flipping into a state where seizures can happen. And so you see the electrical activity all over the whole brain, the whole network all at once. And by contrast, focal seizures, and they have a couple of other names too, partial onset seizures, localization-related seizures, but you mentioned focal. Focal seizures start in a focus. That means there is some spot, some troublemaking spot in the brain somewhere where the seizures come from. And they can stay in that spot, or they can move from that spot to involve the rest of the brain secondarily. You mentioned that for your child, it's been difficult to figure out where the seizures come from. And I can't tell from that description if that means that the seizures are primary generalized seizures, or if they could be focal onset seizures that the testing so far has been inconclusive where they come from. It can be surprisingly challenging to figure out where in the brain that focus is. And sometimes we know that somebody has a focus, but when you do all the tests, it's a more diffuse pattern, or it's confusing where the seizures come from. So that's our challenge. That's our task, to do the best we can and figure out what we're dealing with.
Thank you, Dr. Rao. There's another question. If VNS seems to have less side effects than anticonvulsants can have, why isn't it pushed to be used as a quicker option for children who are shown to be drug resistant in the first year?
That's a very good question. I personally have one patient in my practice who is drug resistant and had terrible side effects with almost every medicine I put her on. So we kept her on the lowest dose of the best medicine, and then she got VNS. I think the answer to your question really is that maybe we should be thinking about neuromodulation devices earlier in the pathway, but for most patients, medications remain part of the treatment. And that really just comes from our observation that if you do things like RNS and VNS alone, patients don't, in general, do quite as well as they do if you have medications in the background too. So saying that somebody is drug resistant is not necessarily the same as saying that drugs do nothing for them. And we have plenty of patients where medications help, for example, prevent convulsions, but they still have focal seizures, or where medicines help reduce the frequency or the severity of seizures, but the seizures persist. And so for those patients, if you were to take them off their medicines completely, even and just rely on something like VNS, let's say, again, there's always exceptions, but I think my feeling is in general, patients would probably not do as well if they didn't also have some medications on board. But again, a lot of these things are really patient specific, and every case is a little bit different. That's part of why I love what I do, because every case is different and it's not so cookie cutter and algorithmic, but it's also the challenge of it. So I hope that helps.
Thank you. There's one more question. Is there more of a risk of infection with RNS or VNS?
Good question. The infection rates for both are actually quite low. With RNS, the infection rate is on the order of 2 to 3%, which is pretty much the same as the infection rate for any surgery that involves implantation of hardware in the brain. For example, Parkinson's disease patients who get deep brain stimulators to treat tremor and other symptoms, the infection rates are very comparable with that. The VNS infection rates similarly are low and in that same ballpark. And we've learned a lot over the years about surgical protocols that can be done to really minimize the risk of infection. So I think that with any surgical procedure, pain, infection, and bleeding are kind of inevitable risks that one has to accept, but fortunately for both of these treatments, those risks are really quite low.
Thank you. We had one more question come in from Kelly. Are VNS and RNS used in conjunction with medications?
Absolutely, absolutely. So we have a lot of patients who start with medications and their seizures, maybe they get a little bit better, but they don't go away completely. And then they get evaluated for surgery. And some of our patients have had surgery, but they stay on medicines. And then sometimes even surgery doesn't do the trick completely and get rid of seizures. And so they consider other options like VNS or RNS. And we definitely have patients who essentially have been treated in 4 different ways, with medications, with surgery, and with VNS and RNS. It's always a little bit unfortunate when you see that, because it just means that they haven't found the silver bullet early on and they've really gone through a lot. But on the other hand, I always take heart in the fact that we have so many of these things to offer our patients now, and they're not mutually exclusive. They can be used in conjunction. We have some reason to believe that they might be synergistic in some cases where the whole is more than the sum of the parts. I don't know that for sure, but that's an area of active investigation. But definitely they can be used in concert with each other. And that's why I said towards the end that I really think of these things not so much as a this or that, but maybe this and that. And why not? Why not do whatever is gonna have the best chance of improving a patient's seizures?
Thank you so much, Dr. Rao, and thank you everyone for attending today's webinar. If you have further questions, Dr. Rao has some contact information to contact the UCSF Epilepsy Center with your further questions. If you joined via the webinar, you will receive a follow-up email with a link to view the recording of today's webinar, or if you join via Facebook, the Facebook video will be on the Epilepsy Foundation of Northern California's Facebook page. NeuroPace is the sponsor of this webinar series. You can find more information on new treatment options for epilepsy patients at www.neuropace.com. This concludes today's webinar. On behalf of NeuroPace, Dr. Rao, and the Epilepsy Foundation of Northern California, thank you so much for joining us and have a great rest of your evening.